In this lesson, we'll discuss building collaborative relationships with participants in the My Choice program. The objectives for this lesson are to provide evidence on effective ways to connect with participants, to examine techniques for building rapport, and practical tips on building rapport. Connecting with participants in the My Choice program is very important, particularly when using this new evidence-based model of care. The time clinicians spend with participants and their caregivers is important for forming relationships based on trust and respect. Trust and adherence to the plan of care improve when you connect with your participant. Participants who do not feel a connection with their clinician are unlikely to trust them and follow their instruction. A participant must feel the clinician understands their condition and situation and has their best interest at heart. Spending 2 to 3 minutes focused on the participant can reap benefits and build rapport. Take time to let the participant know you care for them, interact with them, and remember you begin building rapport the minute you meet a participant. In addition, connecting with the participant is very important, particularly when using this new evidence-based model of care. Approach your participant as both an expert and as someone who understands their life. Think of yourself as a coach. The idea that I know what is best no longer works in healthcare. Seek collaboration with the participant. Encourage participants to be change agents in their own care because they are best served through a collaborative team approach in which they are a member of the team. Participants who are encouraged to talk about their desires will often reveal clues about their health. Finally, connecting with the participant is very important, particularly when using this new evidence-based model of care. A positive partnership with your participant has a great impact on their outcomes. Take these steps to create rapport. As a clinician, you need to know more about your participant than just their disease process. Find out other information to relate to. Ask them about their hobbies, their children, or their interests, and put them at ease and lessen the anxiety of home visits. When discussing treatment options or care plans, listen carefully, make eye contact, and respond to the participant's needs. Here's a checkpoint. Which of the following techniques helps build rapport with participants? Asking the participant about their disease or illness, providing your perspective on a problem, or asking the participant about hobbies, interests, or their families. Asking the participant about themselves is the best answer. Here's some well-established techniques to help build rapport with My Choice participants. Make a genuine effort to know what is important to the participant. Ask them their perspective on a problem. Listen actively because too often we're busy thinking about what we're going to say and we don't concentrate on what the participant is saying. Chat with the participant. Look for the common interest and use the information the participant is giving to get to know them. Start by understanding them instead of expecting them to understand you. Remember that trying to plan care for the future without any sense of a participant's past is like trying to plant cut flowers. Here's some more techniques to build rapport. Try to see things from a participant's perspective and empathize with their emotions. Be sensitive to their needs and feelings by making empathetic statements. For example, you might say, "This has to be painful." Have emotional, difficult, or personal conversations in private. When you do speak, remember to use simple, everyday words instead of medical jargon. It is important to become familiar with the cultures in their community and keep an open mind to make the participant feel comfortable in telling you about treatments or problems they have. When building rapport, it is vital for the entire team to remember that the participant is a whole person. Our health has spiritual, psychological, and physical components, and each must be respected. Here's another checkpoint. It is essential to remember a participant is a whole person, and health includes spiritual, psychological, or physical needs, or all of the above? The answer is all of these items. When building rapport, active listening and body language make up a large part of communication. Studies show 6% of communication is through words, 38% is through tone of voice, and 55% through body language. When participants have the opportunity to talk, you will often learn much more about their health. Participants and their caregivers must be included in the team because effective collaboration results in the best care and outcomes. By asking, looking, listening, and learning, clinicians can help participants feel they have their best interest at heart. To build rapport, do the following. Follow up on participants. It also builds credibility and sends the message you care. Follow through with what you said you were going to do. For example, if you tell a participant you're going to mail them a list of private paid caregivers, do it. Another way to show you care is to make a follow-up phone call after doing a home visit. It too will make the working relationship stronger and lead to positive outcomes. Here's another checkpoint. What is an important component of rapport building? Is it active listening and positive body language, yes or no questions, or note-taking and documentation? The correct answer is active listening and positive body language. So here's a case study of a real-life My Choice participant who participated in our pilot study. The person lived alone in a first one-story home and had a caregiver who was a housekeeper to assist him. There was a history of anxiety, arthritis, depression, and osteoporosis. The participants' goals were to get back to work or volunteering, to restart counseling, and to have more independence. The person-centered plan of care focused on the following areas: mood, environmental modifications, and work or volunteer activities. In regard to the mood on the person-centered care plan, there was a long-standing history of depression, which she reported had often led to her not wanting to leave the home, canceling appointments, as well as problems managing anger and anxiety. There was an attempt to find a counselor, but there was no luck with that. The person allowed the RN and OT into her home to conduct an assessment. Through rapport building and relationships over 3 to 5 visits, the clinicians were able to elicit need for additional counseling and willingness to retry to improve the mood. The team found a counselor and the participant initiated care. In regard to the environmental modifications, the OT changed a hinge on the dryer so that the door opened the other way and the participant was able to independently do their laundry. In regard to the work and volunteer activities, the participant identified 5 places to volunteer and started volunteering 1 day a week. And she stated, "You gave me the push I needed to call them." The participant was highly satisfied with care and stated, "We set 2 main goals and I was successfully able to reach both goals. I feel at the time my depression was so severe I would not have been able to achieve these goals on my own. The home visits and the information given were helpful, and I enjoyed the ladies that came out and I missed their visits." Ongoing care after this intense number of visits occurred were the usual reassessments and monthly phone contacts. In sum, this evidence-based model of care that was person-centered and self-directed, in this case, focused on the desire of the participant. The case provided another example of how, even though the individual had been cared for in My Choice for over 7 years, this new approach truly made a difference in improving the mental status through relationship building. Thank you.